All right, today we are jumping into the world of medical coding, specifically for diseases of the skin. We're going to take what can seem like some really complex guidelines and hopefully turn them into a story that's clear, makes sense, and is easy to follow. I mean, have you ever really stopped to think about that? That simple observation from your doctor gets translated into this incredibly specific language, a code that tells a really detailed story about exactly what's going on. And you know what? Getting that story right is everything. So let's dive in. So here's our game plan. We're going to start with the basics, the real fundamentals of how a code is built. Then we'll get into specific conditions like dermatitis and ulcers, look at some tricky scenarios with cellulitis, and then we'll wrap things up by looking at the procedures used to treat all of this stuff. Okay, first things first. Before you can code anything specific, you gotta know where to find the map, right? You need to understand the basic framework. And this is it. This is our home base. Think of the giant ICD-10 CM codebook. Chapter 12 is our dedicated section, our little universe for everything related to the skin. It covers a huge range, from infections to rashes, you name it, it's in there. And this visual really drives the point home. The codes in Chapter 12, they're not just skin deep. They account for conditions that affect the dermis, that fatty subcutaneous tissue, and even things like the hair follicles and sweat glands. It's a complete system, top to bottom. All right, let's move on to our first specific condition and see how this all works in practice. We're going to talk about dermatitis, which is, one of the most common reasons people end up seeing a dermatologist.
So what are we talking about here? Well, in the world of ICD-10, the terms dermatitis and eczema are pretty much used interchangeably. They both just refer to skin inflammation. The codes for these, which are in categories L20 to L30, help us get really specific about the cause. Was it an allergic reaction to a plant? Or maybe an irritation from a new soap?
Now, this is where it gets really interesting, especially when a drug is involved. This is a critical fork in the road for any coder. You have to figure out, is this skin reaction an adverse effect from a drug taken correctly, or is it a poisoning from the drug being used incorrectly? Because that distinction, it changes everything about how you code it. Let's break that down to make it super clear. On one side, you have an adverse effect. This is when a patient does everything right. They take the drug exactly as prescribed, but they still have a bad reaction. Bummer. On the other side, you've got poisoning. This happens when the drug was used the wrong way. Maybe it was an accidental overdose or they took the wrong pill. The reason doesn't matter as much as the simple fact that it was used improperly. And boom, here is the impact in black and white. Look at this. For an adverse reaction, the dermatitis code, the L code, comes first. That tells the story that the skin condition is the main problem. But for a poisoning, the T code for poisoning comes first, signaling that the improper use of the drug is the star of the show. It's the same drug, the same rash, but the sequence of the codes tells a totally different story. All right, let's keep it moving. Next up, ulcers. And if you thought detail was important before, well, with ulcers, precision becomes absolutely critical. Okay, so when we're coding chronic ulcers, the first thing we have to do is sort them into two big buckets. You have pressure ulcers, you might know them as bed sores, and they get coded from category L89. Then you have all the other kinds, like from bad circulation, and those are non-pressure ulcers, under category L97. And here's a super important rule. If a non-pressure ulcer is caused by something else, like diabetes, you have to code the diabetes first. Now, for pressure ulcers, it's not enough to just say pressure ulcer. Nope, the code demands a 2-for-1 deal. You have to specify both the exact location on the body, is it the left elbow or the right heel, and you have to specify the severity, which we call the stage of the ulcer. And these stages tell a story of progression. Stage 1 is the mildest, maybe just some red skin. By the time you get to stage 4, you're talking about severe tissue loss, sometimes all the way down to the muscle or bone. And there are even special codes for when an ulcer is unstageable, meaning you can't see the bottom of it, and for deep tissue injury. This quote from the official guidelines is so important. It's a common trap. Unspecified just means the doctor didn't write down the stage. The information is missing. But unstageable is an actual clinical finding. It means the doctor looked at it and could not determine the stage, usually because it's covered by dead tissue. It's a subtle difference, but for accurate coding, it's a world of difference. All right, let's keep that momentum. Now we're talking about cellulitis. And if you thought sequencing was the main character before, with cellulitis, it basically is the entire plot.
So first, what are we talking about? Cellulitis is a bacterial skin infection that's pretty common and can be serious. What usually happens is you get some kind of break in the skin, a cut, a scrape, whatever, and bacteria get in, causing all that redness, swelling, and pain.
So here's where we have to ask, what brought the patient through the door? In this first scenario, a patient has a cut, and that cut got infected. Because the initial injury, the laceration, is the main reason for the visit, that's what you code first. It's the principal diagnosis. The cellulitis that developed because of it, that's the additional diagnosis. But now watch what happens when we flip the script. In this scenario, the patient has an infection after surgery. The main reason they're being seen now isn't the original procedure, it's this new problem, this complication. So the code for the post-op infection goes first. Then you specify what kind of infection it is, cellulitis, and if you know the bug, you code that too. See, the sequencing tells a completely different clinical story. Okay, for our final section, let's switch gears a little. We've been talking about diagnosing conditions. Now let's talk about coding the procedures used to fix them. We're talking repair and replacement. A super common procedure you'll see with bad wounds and ulcers is debridement. It's a fancy word for a simple idea, cleaning out a wound by removing all the dead or infected tissue so the healthy tissue has a chance to heal. But how it's done makes all the difference for coding. There are two main flavors. Excisional debridement is what it sounds like. A surgeon is literally cutting away tissue with a scalpel. The root operation for that is excision. But non-excisional uses other methods like scrubbing, washing, or scraping it away. Even though tissue is coming off, the root operation is different. It's extraction. It's a really sharp distinction for two very different actions. And last but not least, skin grafts. For serious wounds, this is how we repair them. The code itself tells a story about where the new tissue came from. It's all about the sixth character in the code. If it's a J, the graft is autologous. It came from the patient's own body. If it's a K, the tissue is either synthetic or from a donor. And, of course, you've got specific codes to capture if something goes wrong, like if the graft fails or the body rejects it. So as we wrap this up, I just want to leave you with this thought. It's so easy to see these codes as just, a bunch of letters and numbers for billing. But they're not. They are the language we use to tell a patient's story. Getting it right means that the story of their sickness, their injury, and their recovery is told with perfect accuracy. And that's a huge responsibility. It really, really matters. Thanks for joining me today.